Hello, everyone, and thank you for joining me. The topic of this on-demand presentation is a detailed look at the standards, Part A, which is the organization. During this presentation, I will review the 2012 organization standards with you, basically standard by standard. My name is Beverly Gorman, and I am the Director of Accreditation for the Echocardiography Division of the IAC. It is crucial to always use the most recent revision of the standards, which are located on the website. The changes or revisions to the standards are always highlighted in yellow. All IAC standards will now share a consistent format, so the laboratory can easily navigate through the accreditation regardless of modality, whether it be echo, vascular, nuclear, MR, CT. All their standards have the same format. The enhanced format will also separate the absolute requirements, or those musts, from the recommendations, the shoulds. So it will be very clear what the laboratory is required to do and what are recommendations, things that you may want to do in your laboratory. During this presentation, I will focus on the standards, the requirements. However, I do strongly encourage you to read the guidelines, the shoulds, because many times the recommendations become requirements in the future. Section 1A of the organization is personnel and supervision. Let's go ahead and look at the standard for the medical director. They must be a licensed physician, and the medical director must meet one of these pathways: Level 3 training in echo or Level 2 training in echo. And due to the additional responsibilities of the medical director, if they are not Level 2 or Level 3 trained, they must have 3 years of echo practice experience and earn testamer status in echo by 2015. And this standard was actually discussed at length with the leadership of the ASE and ACC, and the consensus was that it was reasonable to hold the medical director of the laboratory to a higher standard than the medical staff. The medical director, responsibilities. The medical director is responsible for all clinical services provided and for the determination of quality and appropriateness of care provided, must supervise the entire operation of the facility, or may delegate specific operations to associate directors and, of course, the technical director. They are responsible for assuring compliance of the medical and technical staff to the standards, and they must read studies in the laboratory. CME requirement for the medical director. They must earn at least 15 echo-related CME within the 3-year period prior to application submission. So, for example, if your application is submitted on March 1st, 2013, you can go back to March 1st, 2010. If the CME submitted is older than that or not echo-related, it will not be accepted. So please review those CMEs before you take the time to enter them into the application. 10 hours must be Category 1 AMA. The other 5 echo-related CMEs may be non-Category 1, things such as ASE, CEU, or SDMS CME, things like that. And we actually offer these for some of our live webinars. We offer ASE, CEU, or SDMS CME, so they can also use those credits. They must be kept on file, and if the medical director has completed formal training, and that's Level 2 or Level 3 in echo in the past 3 years, or have earned their testamer status by passing that NDE exam within the past 3 years, their CME requirement is considered fulfilled. So this isn't for just their general cardiology fellowship, but actually formal echo training, that Level 2 or Level 3. Let's go ahead and switch gears and talk about the technical director. A qualified technical director must be designated for this facility. The technical director is generally a full-time position. Now, many times, or many laboratories may only be open 2 days a week, 4 hours each day. So, when you think of the conventional definition of full-time, that's not really full-time. But, again, on the other hand, that is full-time for that laboratory, so that's fine. That's not an issue. If they are in a lab that's open 40 hours a week and the technical director is only there a couple hours a week, that may be a problem. If the technical director is not on site full-time or serves as technical director in another facility, an appropriately credentialed sonographer who's a part of the technical staff must be present and assume the duties of the technical director. Now, the reason for this standard is quite odd, really. It became very apparent that when it was required that the technical director be credentialed, we saw sonographers listed as technical director in multiple labs, even in different states. I mean, we saw them they were TD in Connecticut, in California, in Florida. They were all over the place. And it became pretty clear that basically what they were doing was selling their credential, and it was just putting their name on the application. So that's the background of that standard. Now, the comment, if there are absolutely no sonographers in the laboratory, none, it's all physicians in the laboratory, no sonographers, then the medical director can serve as the technical director. If that's the case, they have to submit the medical director information and also the technical director information and cases. This is the pathways for the technical director, and this one's pretty straightforward. They have to have an appropriate credential in echocardiography. They can be either RDCS, RCS, CRCS, which is the Canadian registry, but they have to have an echo credential, not a vascular credential, nothing else, an echo credential. If there are no sonographers in the laboratory, then a physician can act as a technical director, and they must have either level 2, level 3 training or equivalent if trained before 1998, or a credential in echo. And here's the long list of the technical director responsibilities. They do report directly to the medical director. Their responsibilities include the facilities duties as designated by the medical director, so basically whatever the medical director asks them to do, performance of echoes in the lab, general supervision of the technical staff and ancillary staff. Now, this may not always be the case in your laboratory. There may be a cardiology supervisor or an administrator or something like that that may supervise the staff, and that's fine. Delegation when warranted of specific responsibilities to the technical staff and or ancillary staff, daily operation of the facility, such as scheduling, patient scheduling, record keeping, things like that. Operation and maintenance of the equipment and compliance of the technical and other staff to the IAC standards. And probably most importantly, working with the medical director, medical staff, technical staff to ensure quality patient care and also some technical training. CME requirements for the technical director, again, pretty straightforward, 15 echo-related hours within that 3-year period prior to application submission. And many times we're asked, well, we just met our triennium with the ARDMS. Does that count? That's our 3-year period. No, it's different. We love the folks at the ARDMS, but our 3-year period is different from them. It is from 3 years prior to application submission. And, of course, all have to be echo-related. You have to keep them in file. But if you have earned an echo credential within the past 3 years, your CME requirement is considered fulfilled. Now, we also get asked many times, well, I passed the echo portion of the registry. Does that count for some CME? No, it doesn't. You have to earn your credential before you can consider that CME requirement fulfilled. Medical staff. The pathways for the medical staff differ from the medical director. They must have level 2 or level 3 training in echo, or if training was completed prior to 1998, and they have 3 years of practice experience and interpretation of at least 1,200 echo exams. And this pathway is basically the grandfather pathway for cardiologists. The board did a lot of research and tried to uncover when Level 2 and Level 3 training was widely available or available in most programs, most training programs in the country. And 1998 was the date that they came up with and felt pretty comfortable. By that time, all programs had Level 2 and Level 3 training. So many physicians trained before 1998. So if they have that practice experience and an interpretation of at least 1,200, that's their pathway, and that's kind of the grandfather pathway. Most of the time we hear that these physicians have been practicing 20 and 30 years, and it seems kind of ridiculous at that point to make them, especially since they were just on medical staff, to have customer status. Now, if training was completed during or after 1998 and they don't have Level 2 or Level 3 trained and they meet that practice experience pathway, which is 1,200 echo exams, then they have to have their customer status by the NBE. So, again, but that's only if they're medical staff and their training was completed during 1998 or after 1998. Medical staff CMEs is exactly the same as for the medical director, 15 hours, echo-related, 3 years prior to application submission. 10 hours must be Category 1. The other 5 can be non-Category 1. And if they've completed their formal training, that's Level 2 or Level 3 training in the past 3 years, or earned their customer status by passing that NBE exam, the CME requirement is considered fulfilled, and of course all of it has to be kept on file. Technical staff, they have to be qualified sonographers, and though the standards include multiple pathways by which a technical staff member may document experience and training, the IAC does definitely encourage that all staff members acquire an appropriate credential in ECHO within 2 years of completion of their pathways, and we'll talk about those pathways in just a minute. By 2014, the facility must have a process in place to ensure that all sonographers become credentialed. Now, this standard does not say that all sonographers have to be credentialed. It does say that there must be a process in place to ensure that all sonographers become credentialed. And this could be accomplished by making credential a requirement at the time of hire, or a goal for sonographers already working in the lab, or if you hire a new sonographer right out of school, you may make it a condition of hire that within 2 years that they've passed in, their registry and earned their credentials. So there's many ways to write this out, and we actually have a sample document available on the website to kind of give you a little bit of an idea. So that should be helpful. Okay, now let's go ahead and look at the training and experience pathway for the technical staff. They, too, could have an appropriate credential in ECHO, RDCS, RCS, or CRCS, or successful completion of an ultrasound or cardiovascular technical program, which includes verified didactic and supervised clinical experience in echocardiography, completion of a 12-month full-time clinical echocardiography experience, plus one of the following: completion of a 2-year formal program in another health profession, maybe medical assisting or something like that, another allied health profession, completion of a bachelor's degree unrelated to a KHEP accredited program, or a bachelor's degree in sonography, vascular technology, or a minor in some aspect of ultrasound, which is not KHEP accredited to offer echo. or they may just have MD, DO, or equivalent, minimum of 12 months echo practice experience, and the performance of at least 600 Doppler examinations. Now, if you have somebody that's just come into your lab or is in your lab and they do not meet any of these criteria, they are considered a trainee and should not be included on the application. Staff responsibilities, again, very straightforward. They report to the technical director, assumes the responsibilities specified by the technical director, and basically performs studies in the lab. Their CME is also 15 echo-related CME over that 3-year period. They all do have to be echo-related and have to be kept on file. If they've completed formal training, as we just talked about, or have successfully earned their credential in the past 3 years, their CME requirement is considered fulfilled. On to support services, and we're just going to go over this briefly. The clerical, nursing, transport necessary for safe and efficient patient care are provided. The clerical and administrative support must be sufficient to ensure efficient operation and record keeping. Nursing, again, the same. And supervision, the medical director must ensure appropriate support services are provided. So this is basically, it's just you have to have, support, for the laboratory. I think this is pretty straightforward. Section 2A is the facility. First is examination areas. The studies must be performed in a setting providing patient and technical staff safety, comfort, and privacy. The performance of an echo does require the proper positioning of the patient, the machine, the sonographer, so you have to have adequate space for the bed position changes, the imaging system, and, of course, patient privacy. And we understand that many portable studies are performed, but these still must have adequate space and provide patient privacy. So, again, these are pretty straightforward standards. There must be a sink and soap available in the area for hand washing. Doesn't need to be right in the echo lab, just in the area. So if it's out the door and down the hall a few steps, that's just fine. But it does have to be available for hand washing. Interpretation areas, again, this one's very straightforward. There has to be a space so the physician can interpret and prepare reports. So, again, very straightforward. Storage, there has to be enough storage space for the records and supplies for the volume of the facility. So, again, very straightforward, kind of common sense standards. Section 3A, examination, reports, and records. And this is probably one of the most important portions of this presentation is the reports and the records. And here, these standards go over that provisions must exist for the generation and retention of exam data for all echoes performed. You have to keep them and have to create them and keep them. System for recording and archiving echo data, images, measurements, final reports obtained for diagnostic purposes has to be in place. A permanent record has to be in place and this depends on the state and federal guidelines. So it's generally 5 to 7 years, but you may want to check with your state. It may be longer. And both must be retrievable for comparison with new studies. And now, this is for within your facility, okay? If there was a study done on a patient 3 years ago at a facility, far, far away, it may not be readily retrievable. You may not be able to get it very quickly, and we understand that. But this is for studies in your own laboratory. You have to be able to get the previous study and compare it with the new study. studies must be archived in the original format, videotape, and I think most labs now are digital, and you have to ensure that a sufficient portion of the exam can be archived in digital and that a secure backup system is in place. You don't want to lose those images. Digital studies must include information consistent with that required for video acquisition. However, fewer cycles are generally recorded. And this is basically up to your lab how to decide how many cycles are recorded. Some labs capture 3 cycles, others only 1. It is up to your laboratory. Examination, interpretation, and reports. Again, I think these are the first 2 are very straightforward. There has to be a policy for communicating critical results. What are you going to do if you find a critical result? You're going to call the interpreting physician, tell him what you saw, ask him to come have a look at it. What are you going to do? Findings of stat echocardiogram must be available immediately by the interpreting physician. Okay. Now, this comment, I want to spend just a minute talking about this because I think it's pretty important. Sonographer worksheets, comments, or other communication of findings must not be provided to anyone other than the interpreting physician, not to the patient's chart, not to the referring physician, not to the nurse who stops you in the hall, but only to the interpreting physician. We're seeing more and more sonographers being hauled into court for giving preliminary results or their findings to someone other than the interpreting physician, and it's big trouble. So avoid it. Don't do it. Do yourself a favor. Keep it to yourself and to the interpreting physician. We do realize that those sonographer worksheets, your notes, are just a wonderful tool of communication between you and the interpreting physician. I saw this. What do you think it is? No, let's look at this together. Those type of things. But that should be as far as it goes. It should be just between the sonographer and the interpreting physician. If preliminary reports are issued by the interpreting physician, you have to have a policy in place for communicating any significant changes. So, for example, if the physician looks at the study and says, "Oh, there's just mild mitral regurgitation," he puts that in his preliminary report. Well, and then he sits down later to have a good look at the study and prepare the final report and says, "Oh my gosh, boy, this is moderate to severe, and the preliminary's already been sent." What are they going to do? Are they going to pick up the phone and call the referring physician, send over the final report? Basically a policy of what they're going to do if there's a big difference in that preliminary and final report. And we do have a sample document available on the website just to kind of help you. Now, let's talk a little bit about the timing of when a study has to be interpreted and when that nice, beautiful, signed final report has to be out the door. And it is different for inpatients and outpatients. Okay, so for routine inpatient studies, they have to be interpreted by a qualified physician within 24 hours of completion of the exam. So if I finish an inpatient study on a Friday afternoon at 3 o'clock, that inpatient study has to be read by Saturday afternoon at 3 o'clock. Now, the interpretation is not the final. It can just be they sit down and they dictate the final report, or they may enter it in their workstation. But that's the initial interpretation in 24 hours for inpatients. Outpatient studies have to be interpreted by the end of the next business day. It has to be read by the end of the next business day. So I finish a study on Friday afternoon at 3 o'clock. An outpatient study does not have to be read until Monday by the end of the business day, whether that be at 4 or 5 o'clock in the afternoon. So it's different for inpatients and outpatients. Now, the final verified by the interpreting physician signed report must be completed within 48 hours after interpretation. Okay? So after the interpretation, they have 48 hours to have that final verified signed report. And this needs to be signed and verified by the interpreting physician, not by the sonographer, not by the transcriptionist, but by the actual interpreting physician. Reporting must be standardized in the facility. In other words, all the physicians in your laboratory have to agree on a report format. You can't have one physician still dictating while everybody else, all the other physicians, are using some kind of a new reporting system. They all have to agree on a report format, and they all have to use it. They also must agree on a uniform diagnostic criteria. In other words, if one can't decide, he's going to say 1 plus 2 plus 3 plus MR, and the other ones are going to say mild, moderate, or severe. They all have to agree on both the report format and the diagnostic criteria. And these are the report demographics that are required to be present on all reports: transthoracic, TEE, and stress echo. And if you just want to have a look, there is a sample document on the website if you just want to have a look at it. But these are the demographics that have to be included on all reports: the date of the study, name and or identifier of the facility, name or ID of the patient, date of birth or age of the patient, indication for study, which is going to be very important for your appropriate use, and plus it's also you need to know what you're doing the study for, name or initials of the sonographer, name of the ordering physician, height, weight, gender, and yes, blood pressure. Systolic and diastolic blood pressure must be obtained on or around the time of the study and displayed on the report. Okay. Now, when this first was added to the standards, we heard the sonographers weren't really very happy with this now, but it says around the time of the study. So if you're in an office, you may have a medical assistant that has just taken the blood pressure. Maybe the physician was the patient was just in with the physician, and the physician took the blood pressure and wrote it in the chart. You can certainly use those. If you're in a hospital setting, look up at the monitor, look what the blood pressure is, or maybe it's just that the nurse has just taken the blood pressure. You're welcome to use those. But let's say you're alone on a desert island with your patient, your patient, and the machine, and you have to do this study. Guess what? The sonographer may have to take the blood pressure. So there are many ways that you can get help with this, but in the end, there does have to be the blood pressure on the report. And the information must be sufficient to allow for the ID and retrieval of previous studies on the same patient. So, in other words, there just has to be enough information for you to find the old study. These are pretty straightforward also. There has to be a summary of the results of the exam, including any pertinent positive and negative findings. Basically answer the question for why you were doing the study. It has to be completely typewritten, including the printed name of the interpreting physician. The final report must be reviewed, signed, dated either manually or electronically by the interpreting physician. Electronic signatures must be password protected, and I don't think that's an issue. I think most systems now make you have a password, and indicate that they are electronically recorded. It's always nice if the report says it's electronically signed by, Dr. Jones. Stamped signatures or signing by non-physician staff is unacceptable. So the transcriptionist can't type up the report and put a rubber stamp on it and say it's good to go. She can't have the sonographer sign it. the physician has to review that report and sign it, either manually or electronically. Let's have a look at the specifics for adult transthoracic reports. They do have to accurately reflect the content and the results of the study. I think that's pretty reasonable and straightforward. And these are the 2V and/or M mode data that has to be included, the measurements performed during the exam and/or interpretation, because we know many times now measurements are done offline. 2D and/or M mode data for transthoracic echoes must include measurements of the LV internal dimension at end diastole, LV internal dimension at end systole, LV posterior basal free wall thickness at end diastole, ventricular septal thickness at end diastole, left atrial dimension at end systole, or indexed LV volume, either one. It's up to you. It's up to your lab if they want to do volume measurements or just the LA dimension. And aortic root dimension at end diastole or ascending aorta. Normal ranges may be included on the report. I think it's kind of a nice feature to have those normal ranges on your report. But the report must comment on whether a given dimension is normal or abnormal. But especially those normal ranges for the referring physicians. You know, they may not remember what the normal range is for the left atrium or left ventricle, things like that. So I think it's always a nice idea to add those normal ranges. Report of the Doppler evaluation must include evaluation of peak and mean gradients, its stenotic, valve area, degree of regurgitation, right ventricular systolic pressure when there's tricuspid regurg, and other pathology. And I'm going to tell you that the peak and mean gradient is very, very often left off of reports. We'll see a very nice report, and they'll have the aortic valve area. They may have the peak gradient, but they've left off the mean gradient. So please, they're all required, peak and mean and the valve area. And if there's TR and you can measure that, then the right ventricular systolic pressure. So very important. The report text has to include these comments: the left ventricle, the size, ejection fraction, and regional dysfunction if present. If there are no regional wall motion abnormalities, it's, I think, a good idea to say there aren't. However, if there are, they should be described. Right ventricle, size and function, right atrium, left atrium, mitral valve, aortic valve, tricuspid valve, pulmonic valve, pericardium, and aorta. Now, if, let's say, for instance, the mitral valve is normal. It's perfectly normal. That's fine. Then they can just say the mitral valve is normal. But I will caution you, if there's, let's say, mild MR or moderate MR or something, it's always a good idea to actually describe the mitral valve structure. So a lot of times you'll see that they'll just say mild MR or moderate MR, and they won't even talk about what the valve looked like. So just a little caution there. If any structure is not well visualized, this must be noted. And, of course, the pulmonic valve is usually the culprit that we can't see very well. And so if they can't, they just have to say that it wasn't well visualized. And the report text must be consistent with the quantitative data. Now, this is what we call in-house here an internal inconsistency. And that is when, let's say, for example, you have the left atrial measurement reported as 5.2. But then in the text or the body of the report, the physician will have said the left atrium is normal. Okay, well, that's an internal inconsistency. So please be very careful and review your reports for that. And where appropriate, they must include localization of quantification of the abnormal findings. So again, we have a really nice checklist for your adult transthoracic, your TEE, your stress echo reports posted right on the website. So if you want to use those, there makes it like nice and easy just to check and say, okay, left atrium, yes, it's in the report. Right atrium, yes, it's in the, whatever. You just go down the list and check your reports. Okay, a little bit about TEE reports. Again, they have to accurately reflect the contents of the study. They must include medication used for the procedure. Did you give the patient some fentanyl, some Demerol? Versed, what did you give the patient for the procedure and how much? Ease of transducer insertion, complications, if any, and then components of the procedure. Color flow Doppler, PW, CW, contrast. The report text must include all of these comments, and they're, again, pretty straightforward. LV, RV, RA, LA, left atrial appendage, interatrial septum, mitral valve, aortic valve, tricuspid valve, pulmonic valve, and pericardium and aorta. And if the structure is not well visualized, it has to be noted. And these are the Doppler comments for your TEE reports, linear volume area measurements, color and spectral Doppler interpretation, statements regarding antegrade and retrograde flow abnormalities for each valve, along with any other Doppler of velocity, gradient, volume measurements, whatever is generally accepted or needed for documentation of pathology. So again, very straightforward. Stress echo. Let's switch gears again and talk a little bit about stress echo reports. Again, it must accurately reflect the content in the study results. So I think that's pretty reasonable. The report text must include the following non-imaging data. Now, many times we'll see that, for instance, the internal medicine physician has supervised the stress portion of the exam. Okay, they've actually done the exercise, the stress test interpretation, and that's fine. That's absolutely fine. But I will caution you that the stress echo report, okay, does have to include this non-imaging data. Okay, exercise time, or maximum dose of the pharm agent used, target heart rate, maximum heart rate achieved, whether or not the target heart rate was achieved or stress was adequate, blood pressure response. Was the patient's blood pressure response normal or abnormal? Many times we'll just see that the blood pressure was taken at the different stages, but nowhere does the physician say whether the blood pressure response was normal or abnormal. Reason for the termination of the test. Patient's legs got tired, or they got short of breath, or whatever happened, why you stopped the treadmill. Patient's cardiac symptoms, if any. And then summary of the stress ECG findings. And here's that comment. This was kind of what I was talking about just a minute ago. If the ECG portion of the stress test is reported separately, the imaging report must include all of those items that I just described. So, many times we'll see that you'll submit two totally separate reports, and that's not acceptable. That stress echo report has to have this non-imaging data on it, and then for the image description, you have to have pre-exercise segmental wall motion comment. Was it normal at rest before exercise? Or was let's say, for example, the inferior wall hypokinetic? And then the overall global function, okay? Was the overall function normal, mildly reduced, moderately reduced? What was that global systolic function? So, again, that's two comments for the LV prior to exercise. Then post-exercise, you have to talk about the wall motion comparison and the global systolic function. In other words, were there any changes from the pre-exercise or the resting images with the post-exercise wall motion? Did one of the walls become hypokinetic and it was normal at rest, that type of thing? And again, the global systolic function. Did it become hyperdynamic or, was it reduced? Whatever it was. So, again, make sure your stress echo reports have these comments. You have to have a summary of results, including pertinent positive findings such as ischemia, viability, and coronary distribution, LV cavity size, and EF response, and negative findings. An accurate, succinct impression, normal, abnormal, stable, must clearly communicate the results of the study and, when possible, answer the clinical question that was the cause for the examination. In other words, try to answer the question. This final conclusion must resolve any inconsistencies or discrepancies. For example, an abnormal stress test with normal images, or provide guidance for further studies to do so. So if they just don't know and they think they need to go on to have, a nuclear study, then the report should go ahead and recommend that. Any need for additional studies based on the results of the procedure being reported. And that's what I meant. Send them, recommend a nuclear study. Section 4A is the facility safety. Patient-employee safety is ensured by written policies and procedures approved by the medical director. Okay, and this is the ergonomics policy, and a policy must be in place to address technical staff safety, comfort, and avoidance of work-related MSD. All of us sonographers know how important this is. We all have aching backs, sore shoulders, our hands are numb. So it's very, very important to have a policy and procedure in place to try to avoid these types of things. And we do have a sample document available. I will warn you it's a little bit lengthy. I think it's like 16 pages, but it has a lot of good information in it, and you're certainly welcome to adapt it to make it fit your laboratory. But go ahead and have a look on the website and read over the policy and then make it fit your laboratory. And this is a pretty important standard also. All of them are, but this tells you basically what you need to have on hand if you do stress echo and TEE in your laboratory. Standard exams are considered safe to both the patient and the sonographer. However, special procedures like TEE and stress echo do pose potential risk to the safety of the patient due to either semi-invasive nature or the physiologic stress placed on the cardiovascular system of the patient. So for this reason, the echo facility providing these special procedures, TEE, stress echo, must have an emergency plan. Okay, what do you do if there's an emergency? Do you call the code team? Do you dial 911? What do you do? The following emergency supplies must be readily available for TEE and stress: crash cart, defibrillator, equipment for starting and maintaining IV access, oxygen tanks or wall-mounted oxygen sources with appropriate cannula or mask. And I hear especially some folks in offices aren't crazy about this standard, but you know what, really, it's not that hard to do. I've seen it in many places. They have a huge tackle box that has all the drugs in it. They have defibrillators, are not hard to get anymore and not that expensive, and IV equipment. This is all doable, and it's for the safety of your patient. So you have to have them if you do TEE or stress or both. The facility must meet the standards set for by OSHA and the Joint Commission, and you have to have a procedure in place for handling acute medical emergencies. And it is whatever you do in your laboratory. Section 5 is administrative, and this is patient confidentiality, which is basically HIPAA. Facility personnel must describe professional principles of patient-physician confidentiality as legally required by state, federal, local, institutional policy or regulation. Again, this is HIPAA, so we all have to have it. Patient and/or customer complaints, you have to have a policy that outlines the process for patients or other customers to issue a complaint or grievance. Of course, we're never going to have that happen, but you have to have a policy in place. If they're going to complain about the care or services they received at your facility, or so basically how the facility handles these complaints or grievances. And primary source verification. You have to have a policy in place identifying how the facility verifies medical education, training, appropriate license, basically that you have a physician's license on file, your sonographers, their credential cards, things like that, that you just have to have a policy in place and follow it. These two, the patient complaint policy and primary source verification, were mandated to us by the Centers for Medicare and Medicaid as part of the NIPA law. Now, even though echo and vascular are not included in the NIPA law, since we are one IAC and the IAC has been deemed an accrediting body, we are all responsible for complying to their rules. So, again, these last two policies are mandated by the CMS. And we do have sample documents available, so please feel free to go on the site and download them and make them your own. Section 6A is multiple sites, fixed and or mobile. Now, on March 28, 2011, the IAC announced a policy change related to mobile services. At that time, the previous mobile service policy was eliminated. It's gone. And the current multiple site fixed and or mobile policy was put into effect. And this change was also mandated by the Centers for Medicare and Medicaid Services. So we were not allowed to accredit mobile laboratories anymore. They have to be multiple sites, which is a good thing because then they are required to submit cases and QA and the whole thing just as everybody else is. The complete updated policy is published on the IAC Accreditation Program Policies and Procedures. It's Section 3 on page 6. And this can be found on our website from the home page under the Legal tab. So, again, it's no more mobile. It's all multiple sites. And for your multiple sites, they all have to have the same medical director. They have to have the same technical director. They have to use identical protocols. They have to have identical diagnostic criteria. And quality assurance must be evaluated for each site for all areas performed at that site. Okay, so, and they have to have the equipment of similar quality and capability. So pretty straightforward. Again, it's basically like they're one lab. They are one lab. They have the same medical director, same technical director, use the same protocol, same diagnostic criteria. They all do QI, and the equipment has to be similar quality. In other words, you can't have, a 25-year-old site, a piece of equipment at one site and a brand new system at the main office. So you kind of have to keep them similar. Help, you have questions, please, I can't stress this enough. Don't get frustrated. Don't feel stuck. Don't listen to what you've heard on the street. Please just pick up the phone or send an email to us. We'll respond very promptly. For general application questions, please contact Sade Cannon. She's our senior application specialist. Amy Woodall or Alex, all three of them. For general application questions, they are awesome. With the application, if you get stuck, you can't get a document to upload, or, if something, you're just not sure how it works in the application, or you have a question about fees or things like that, please send them an email, pick up the phone and call them. They're more than happy to help you, and they're very, very knowledgeable. Now, for technical questions, again, don't hesitate. Either email us, pick up the phone and call us. We have, including myself, there are 3 sonographers on staff, Sandy DePetris, Frank Vermeeren, and myself. And between us, I'm sure, well, I actually hate to admit, there's over 60 years of echo experience between the 3 of us. So, again, we can offer suggestions. We can answer your questions. If you have a situation you're not sure how to handle, please just pick up the phone or send us an email. We're very, very happy to help you. That's what we're here for. I hope you found this presentation helpful, and thank you for your attention and your interest in the accreditation process.